Okay, it looks like we're live, Ilana.
Hi. Hi, Peter.
Hello.
I am actually hosting Tea Talks today. I am sitting in for our well recognized, well received host, Sharon Gill, who had a conflict today. So she was kind enough to ask me to sit in. So
Yes, and
welcome.
thank you for Lana for stepping up to the plate, as a true total health team player always does.
Uh, anyway, I wanted to introduce you, Peter. Many of you have probably seen Peter on the show before. Peter
I've been on the
Shovelino. Peter
show. You know,
Shovelino.
yes,
I got that right.
you
He
got it
is the
right.
director of medical writing and scientific content for Total Health. And I am
Yes,
actually their director of partnerships. So you have a Total Health team today.
yes,
And today we're going to talk about something that's been really important to this team. It is intertwined into the fabric of many of the meetings that we're holding throughout the year. And it's really the importance of diversity in cancer clinical trials. And so diversity is very important to total health in many different ways, but specifically today we're going to talk about clinical trials. So I think I'm going to just start off with a very basic question to you today. What is the problem?
yeah,
Is that
yeah.
minorities, underrepresented people are really not represented in clinical trials, especially cancer. Can you talk a little bit about that?
Sure. Well, as you know, Ilana, cancer equity is a huge part of what we do at Total Health, and first of all, so much going on in the last couple of months, right? At Total Health, we've got some new people on board, and we have the launch of the Cancer Equity Project,
That's
which
right.
is super exciting. And where I kind of get the idea of that we should highlight this on T Talks is we had a virtual one of our Seek virtual programs. We had a great panel discussion with an all female group of expert clinical people, uh, uh, moderated by Dr. Shika Jain, and one of the issues that just keeps coming up all the time as I learn more about the problems of inequities in cancer care is just this just profound
That's
underrepresentation
right.
of minority populations in clinical trials. And there's a lot of reasons for this, which we could certainly get into. But the fact of the matter is, the scope of the problem is that, I mean, I'm going to take the example of like a major clinical trial that was came out for breast cancer last year. I mean, and this is the case not only for breast cancer but for really a lot of cancer clinical trials, the majority of clinical cancer trials. I mean, if you talk about a population, the demographics are just overwhelmingly in Caucasians. And if you look at that specific trial, not to mention a trial by name, but the Black enrollment in that clinical trial was less than 5%. And what we really need to understand is why that's a problem. Because when we think about cancer clinical trials, we're thinking about the randomized, double blinded, placebo controlled. I mean, these are the trials that are like, there's a new treatment and we're uh, testing it at this particular indication for this particular cancer, and we want to know if it's safe and if it's effective. And this is the kind of a trial that the FDA, bases its registration on. The approval of drugs are based on these kinds of trials, and based on those results of those trials, if they're positive, they can be practice changing. They can change what we call the standard of care. So when results are positive, often we have major guideline agencies recommending, this particular agent or this particular treatment paradigm for this particular cancer. But what the problem is, if that trial population is overwhelmingly Caucasian and hasn't had adequate representation of all really the demographic group, I mean, at least in as a component of the United States population, at least if we're not representing those groups appropriately, then really these recommendations cannot be applied to all of the specific minority groups that may be underrepresented in that trial. And that is the real problem. That is the recurring theme of things that need to change as we talk about inequities in cancer care. There's just this profound underrepresentation of minority populations in clinical trials.
Peter, it seems so obvious, right? Like that we're missing that. But why do you think that minorities are not enrolled in clinical trials? There's got to be a reason that's happening?
Well, there's a lot of components to this. It's a big problem. It's not something we're going to solve overnight. Certainly, one of the things that we have to understand is, and I've been learning a lot about this myself over the past couple of months. So we've got some.
I think we both have. That's right.
Some great experts in this area. That historically there really has been kind of this inherent distrust of the medical situation, certainly clinical trials, for a lot of minority populations, and it is based on some real historical injustices in this area, which I didn't even really know about. So, at some level, there is, for underrepresented populations or minority populations, there is a real distrust of the medical system, especially when we're talking about something as serious as cancer. It pervades your whole psyche when you get that diagnosis. So that's one of the big problems. Another big thing that, and I have to caveat this by saying, clinicians have a hard time of it these days, but, there may be some inherent biases that clinicians feel towards, this person has a lot on their plate. They may not be the best candidate for a clinical trial. And one of the issues that Dr. Jane had raised in her presentation was, they don't like to use she never likes to use a word like, this patient is going to be
non-compliant.
He doesn't like that word because, we shouldn't be thinking that the patient is non-compliant. We should be thinking about what are some of the barriers to this patient participating in this clinical trial that maybe we can address, maybe we can try to overcome for this particular patient. And they're also, from that perspective of just the whole distrust of the medical system, there has to be a lot more community outreach, specifically in populations that may not be by a major academic center. And another issue too is when we're thinking about the administration behind clinical trials, and it helps. And I've heard this again and again. It helps when the patient looks like you. It helps when the patient talks like you. That's just the reality of it.
Right.
Not only from like a Hispanic perspective of language barriers or anything like that, but just to have someone who can relate to you on your level.
Or even speak your language, Peter.
Exactly.
I when you mentioned Hispanic, I'm based here in South Florida. Some of the issues are just that, the information's not available, in Spanish for them to be able to, or their doctor doesn't speak Spanish to communicate with them.
Absolutely. And, another point that was raised, and that was a great presentation. I'll put the link to it. It's free on YouTube. I recommend everybody watch it, but it really kind of gets to some of these issues is, as clinicians, they tend to use a lot of jargon, and it's like, it's a lot for anybody to understand, but, there really needs to be a resource there where patients can understand the implications of being in a clinical trial.
I see a question from actually one of our team members, and Raquel's asking, like, what are some of the inherent biases that can be eliminated? Clearly we can talk about language, right? Right? We have our own, and I've learned this through our own workshops, have our own microaggressions, right? that we
Yeah, there's a
automatically
great
make.
another really great presentation by I'm sorry if I forgot this person's name, but it's really a great thing on microaggressions and just things that used to be. I mean, to me, they were a little bit of a kind of like an activating word. Like we hear things like white privilege, but it really helps to it really helped me to kind of understand some of the inherent like microaggressions that might be felt by just talking about this kind of a thing with them.
You know,
So in terms of, how can we reduce those biases? Just certainly just awareness. Why
yeah.
are you thinking this person might not be a candidate for a clinical trial? Um,
Sometimes it's as simple as somebody, the way they look, or if they came in. We heard something that was so obvious from a Hispanic doctor who had already had a patient, has another Hispanic patient had already walked in their, their room to be taken care of. And the doctor already made a decision that that patient, they weren't going to talk about a clinical trial because the patient didn't come with a family member. And inherently, Hispanics, in her mind, as a Hispanic woman doctor, that it would be a waste of her time. And so there
yeah.
are so many things that we can, hopefully eliminate. Would you agree with that? There's simple things there from a training
Yeah,
perspective.
so
Even.
absolutely. And in answer to Raquel's question, just the overall awareness of that. Why am I thinking this way about this particular patient? And again, I have to give it to clinicians. They, they this came up in the GI discussion as well. I mean, Dr. James was saying, he's like, sometimes they're based on how many patients they're seeing, and it takes time to
Sure.
consider a patient to really, to be in a clinical trial. That takes time, and when you've got people lined up out the door.
And money.
She even said it's like a factory. That's no way to be treating patients. But I want to also touch upon clinical trials can be a real way. I mean, we think about the costs of cancer care that can be certainly overwhelming. I mean, even for people with insurance, but let alone people that are uninsured or underinsured. So clinical trial participation, it can be a way to kind of offset some of those costs. People think about, well, what if I'm on the placebo arm? And what it's important for people to know is that nowadays clinical trials have to be designed ethically. They have to be, if you're not on the active treatment arm, you're still getting the standard, what we call the standard of
That's
care.
right.
This is the best that we can do for you right now. You're going to get that, and you're probably going to get that at a lot less than it would have cost you, if you tried to do this on your own. So it is a way for, certainly underserved, underinsured populations to be have more access to the latest and greatest. And another important thing is this concept of crossover. Oftentimes, if there's something that's so groundbreaking and it's the active treatment arm is doing so much better, most of the time you will have the opportunity to cross over
That's
to
right.
active treatment. So you're still getting the latest and greatest in cancer care. So it's so important that, first of all, that we do think about considering more minority patients for our clinical trials. And, there are still barriers to this, but um, some of the other things, again, I will post this in the comments, but this great GI cancer panel, they're really brainstorming about what are some of the ways that we can expand, that we can think about breaking down some of these barriers. Transportation, a huge barrier. Sometimes people don't live close to an academic institution.
That's right.
So one of the things that the panel was discussing was, the use of telemedicine. I mean, this has been a huge groundbreaking thing with COVID. It's like we realized that, my God, there's so much we can do with telemedicine that can make this so much more, that can make cancer trials that much more accessible for patients. For example, if you're not on the active treatment arm. You can manage this clinical trial, being in this clinical trial, through your primary care physician with like a once a month telehealth visit. How are you doing? What are the side effects? How is it going? And, patients are still able to be on that active treatment where, you're getting the best in cancer care that you can get. But in the context of a clinical trial. So how do we make that more accessible?
I have a question that I think that if, listening to this and not knowing, I mean, I am a huge, huge proponent of clinical trials. My dad, and I'll just tell this 2 seconds, he was in a clinical trial out of Memorial Sloan Kettering many, many years ago. And they were looking for people who had melanoma with 2 metastases with no primary site. And he went on this, he lived for 25 years, and it was just, believe me, I am always very, very grateful. But the one question I have, how do people find out where you get clinical trials? How do you know, other than from your own physician, how do minorities specifically, are there websites available? Can they ask their physicians about this? I think through our own Total Health, and I'll just sort of give a shout out. Total Health launched a nonprofit arm called the Cancer Equity Project. And thank you, Sharon, for reminding us how important that is in terms of the work that we're doing, is, starting to look at these things, right?
Absolutely.
Cancer equity. But to me, there's so many things that we have to, bring to the table. I remember, Peter, you talking about and I hope this is okay, that, one of our team members, and your wife both went through breast cancer at the same time. One was offered a clinical trial and one was not. Mm-hmm. How do we bridge those gaps?
Yes, well, certainly one of the big issues too is, I've heard this many times now, is that patients especially minority patients, they're just not asked about this. And so one of the big ways to break down this barrier is just like, hey, if you're considering this patient for a clinical trial, just ask them. And a lot of times when patients are asked about it, they are very receptive to it. And then, if there are barriers, then it's about, how do we break that? How can we make this more accessible to you? But I want to get back to Sharon's question too about, one of the, we talked about the launch of the Cancer Equity Project, which is, it's a huge part of what we're doing now at Total Health. And one of the pillars is a clinical trial that's going to be designed specifically for Black women with breast cancer. And it's a huge issue. Again, 40% increased risk of death from the same type of breast cancer as their white counterparts.
Incredible.
So what is that? We need to it's a multifactorial issue. There may be genetic factors. There may certainly be social determinants of health that we're talking about here that, prevent patients from continuing their treatment, from completing their treatment. So certainly, this is one way that Cancer Equity Project is looking to do this by having this project, which this clinical trial, which is called Ebony, which is going to aim to exclusively enroll, or predominantly enroll, Black women who are an at-risk population. Because, as I was saying, the lack of inclusion in clinical trials, there's a real lack of data there. That's right. Until we have the data from the clinical trials, we can't begin to understand these issues, and we can't begin to address them unless we understand them. So the problem of underrepresentation, it is a big issue, for sure. And the other thing too, which we're doing with Cancer Equity, I just saw Sharon reminding us of this, is this Cancer Equity Journey Map, which is just like I think it's going to be a phenomenal resource.
I do too.
You have a specific type of cancer that's kind of taking you through what you can expect from your cancer journey. And, certainly I think if there's opportunities for clinical trial enrollment there, that's going to be identified to you.
Yeah.
And so,
I find that so, I mean, I think that's going to be a game changer. I
sure.
really do. I mean, you talked about Black women being underrepresented in terms of that. And we had a guest the other day on and just talking about Mexican descent, and
Sure.
that, it was really eye-opening to me that, women of Mexican descent have a different genetic makeup than maybe
Mhm.
one from Venezuela or a Caucasian or a Black woman. And in terms of how they're treated, or in terms of their risk of cancers was,
Yeah,
or
it's absolutely true for a lot of these underrepresented populations.
yeah, I think we have another question that I think is so important for Maddie. It says, what do you think what steps do you think medical institutions could take to make clinical trials more accessible to patients? I think you've hit on some of that, but we've
Yeah,
got to be able to brainstorm and look at more opportunities.
sure. I just think first and foremost, think about, as a clinician, and again, I give it to clinicians. They're very, they have a lot of challenges right now. But if you are considering a patient for a clinical trial, just ask, because, see if they're interested. And, if so, what might be the barriers to their participation? Is it transportation? Is it, follow up? Is it, accessibility? For
Is it
these.
fear?
Well, exactly. And, there's a need to understand the risks, and, understand that informed consent. Have it presented by somebody who looks like them, who talks like them.
That's the key.
Certainly, community outreach. It's a huge thing that needs to be done by a lot of these institutions. You got to understand, and you got to. I think it was Dr. Elise Lower that said, these people are not going to come to you. These
That's right.
populations are not going to come to you. You have to go and actively seek them out, get them in for that screening.
That's a perfect tie into our Seek Color workshops, Peter.
Absolutely. Yes. And yes, great point, Ilana, that, just learning. I mean, I've
That's
learned
right.
a lot in the past couple of months just
I
from the
think we all
that
have
we've done.
about that. You said
Just
something.
great.
You said something, and I think we'll, at this point, wrap it up. We've taken up most of, a lot of time for these people, and greatly appreciate you tuning in. You said something, and I'm going to end it. And Sharon always says that I'm going to give you a hint of how, to end in terms of these tea talks. It's always a good feeling. But you said something, and if you can take off from this, you said something. Sometimes it's just simple as asking.
Yes, absolutely.
Yeah,
No,
just
for
simple
sure.
as asking.
For sure. And I know Sharon always likes to end on a positive note.
That's right.
So, what's going to inspire you and make our T cells happy today? I mean, I don't know about you, but I'm just so inspired by what we're doing at Total Health. I mean, and with for me, as being 25 years in the medical education business, say you can't teach an old dog new tricks, but I'm really I'm loving what we're doing here. It's so important. It's so impactful. It's not a Black issue. It's not a white issue. Cancer is everybody's issue. And, as
That's
we get
right.
older, it's going to affect somebody in your life if it hasn't already.
And younger, Peter. We're seeing more
Yeah,
and more younger
absolutely.
people.
And this is something, and, just this is a cause that we can all get on board with.
That's right.
And, I think in, striving to increase our enrollment of minority populations in clinical trials is definitely a way to get there. But yeah, I'm really inspired, and I can't wait to see where we're going with Total Health and Cancer Equity Project next.
Thank you. And if
Yes,
Sharon,
Ben, super,
if we
super
can,
excited. Thank you so much for taking the reins today. I don't want to be doing this by myself, but and yes, we have a comment from Sharon, who's
thank you,
happy to have
Sharon.
you. And we are happy to have you, Sharon. You inspire us, and you've grown from our leader to our colleague here, from our leadership coach to our colleague.
That's
And
right.
so we're so pleased to be working with you as well. And
Thank you, everybody. Thank you.
Bye-bye. We'll
Thanks,
see you
Peter.
next time.
Thank you so much. Bye.
Thank you.